Okay, Assalamualaikum. Sebelum kita mula, ada sedikit housekeeping punya nasihat ni. Kita sila pastikan semua mikrofon dalam keadaan mute sepanjang presentation. Sesi soal jawab akan selepas Dr. Tuang habis bagi talk.
Yeah.
Yang ketiga, pendaftaran dan ECG QR code akan diberikan pada hujung sesi.
Yeah.
Okay. Okay. Okay, kita mulai. Good morning. Good afternoon, Assalamualaikum, and warm welcome to everyone. Thank you for joining today with CME webinar organized by Unit HIV STI and FC JKNJ Johor. My name is Dr. Radiatun, Medical Officer from PKD MUA. I'm honored to be your moderator for today's session, titled Primary Care Management of HIV, Why TLD First. For decades, HIV treatment involved high pill burdens and complex medication schedules. The evolution to TLD, single fixed dose combination of tenofovir, lamivudine and dolutegravir has revolutionized global HIV care with high genetic barrier to resistance, a rapid virus suppression and a favorable side effect profile. TLD represent the modern standard of care. Understanding this evolution is crucial for us, primary care, to optimize patient adherence and improve long-term outcome. To walk us through this clinical rationale behind this approach, it is my absolute pleasure to introduce our speaker for today, Dr. Tuang Wei Xuan, infectious diseases physician from Hospital SUltanah Aminah, Johor Bahru. Dr. Tuang is an esteemed clinician, researcher, and also an educator who served as a mentor for both Newcastle University and Monash University, Malaysia. She completed her Ministry of Health Infectious Diseases Fellowship in 2022 and was recently awarded the Fellowship of the Royal College of Physicians of Edinburgh in 2025. Without further ado, Dr. Tuang, the virtual floor is yours.
Good afternoon to moderator Dr. Radiatun and everyone. First of all, I'd like to thank JKNJ, Uni HIV STI, Dr. Nasrullah and Dr. Nuru for help to organizing this and giving me the opportunity to present on this topic, primary care management of HIV, YTLD first. I believe that all of the healthcare workers are providing HIV care to are actually exciting and have been waiting for the launch of TLD and the usage of TLD in primary care in order to help to improve our patient outcome. So let me start my presentation. So first of all, I would like to recap a little bit on the overview of HIV/AIDS epidemic in Malaysia. So each year we have around 3,200 to 3,300 new HIV infection. Total reported HIV cases since the beginning of the pandemic from 1986 until now, which is already 30 years reaching this year. Up to 2023, there's about 5,000 cases reported. In year 2023 alone, there's 882 reported HIV/AIDS related death. So total of HIV/AIDS related death over the past 30 years is around 63,000, and the total living people is around 71,000, with the notification rate of 9.7 per 100,000 people. So among the new HIV infection reported in 2023, about 10% were from women and girls, and about 90% from men. So total number of children reported, which is less than 13 years old, was 8 cases, and total number of children less than 13 years old reported from the beginning of the pandemic was 1,236. Out of all these, total about 69,000 PL/HIV got it by people who injected drug, and the rest from sexually transmitted. So this is a graph to show the proportion of male and female patients. So we can see that the graph has about 10% of the PRHIV are women and 90% were men. If we look at the transmission by risk factor, about 2/3 were homosexual or bisexual, about 33% were heterosexual, with nowadays very less of them make up of IVDU, 0% mother to child transmission. So as for the transmission by age in 2023, mostly affecting age group of 20 to 29, followed by 30 to 39 years old. So this is the gap between our current treatment cascade and the goal. We would like to try to achieve the target of 95, 95, and 95. So as we can see that there's still a gap between what we have achieved and what our target is. So this is to show that over the years since around 2022, 2023, 2012, 2013, the number of new HIV diagnosis has reduced, and the number of sexually transmitted being the cause is currently making out of about 95%. So actually TLD is not something new. It has already been recommended by WHO since the year of 2018. So WHO recommended the dolutegravir containing regime as the preferred first ART regime for PRHIV since the first guideline in 2018. So at that time, the preferred first line was already stated as or emtricitabine with dolutegravir, and the efavirenz has been moved to an alternative first line, and also other options in terms of special circumstances. So again, in updated guideline by WHO in 2025. This is December 2025. It has again stated that a combination of first-line ART involving either TDF or TEF with lemivudine together with dolutegravir being recommended as the first-line therapy. So according to an update on the transition to dolutegravir-based ART as first-line regime in 2021, which is 3 years after the first recommendation, 110 low to middle income countries across the world have transitioned to dolutegravir-based regime as first line, with an estimated 22 million people receiving DTG-based ART. However, the relatively high cost of DTG still represent a significant burden and also hindrance for its wide use in Malaysia. So I would like to share a little bit of chronology of getting TLD as first-line ART in KKM. So since it was recommended by WHO, after that there was a discussion regarding to get this TLD combination into the Malaysia healthcare system through various programs in KKM, by medication patent pool, UNAIDS, WHO, Third World Organization, and also Malaysia AIDS Council. Then there were continuous discussion, for example, the analysis of the need and also justification, and also implication in terms of economy, impact to transition to TLD care. So in 2024, there were several different meetings at the KKM level, special meeting regarding the Kertas Dasar, and also presentation at different levels. Then by June 2024, the progress made is that it is generally agreeable that TLD should be used as a first-line therapy. Following that, there was chronology of approval as well. So it is planned to be implemented as stages. So with target of currently PRHIV who are receiving ART treatment with dolutegravir, be it the existing and the new one, target to increase by year 2025, 2026, and 2027. And it should be given at all facility, including hospital and also clinic kesihatan setting. So the tempo pelaksanaan is planned to be peralihan besar-besaran from 2025 to 2027. And by this measure, hopefully to bring down the price rise of this TLD or dolutegravir-based regime into a treatment cost of in between 95 ringgit per month. And hopefully with this, the price can be further bring down year 2028 to 2030. All of us being either working in the hospital or primary care should be the pelaksana. So following all those efforts, KKM has just released a new circular on 29th of April 2026, which is 1 month ago, regarding the implementation of TLD as the primary regime for HIV treatment in all KKM facilities. This is actually part of the effort to try to achieve the goal of ending AIDS by year 2030, and this is actually a global goal. So by strengthening the access to effective, safe, and quality HIV treatment in line with the recommendation of WHO. The implementation of TLD regime as a first-line ARV plays an important role in the effort to increase treatment coverage and also prevent the transmission of infection. So how to justify to implement TLD as first-line treatment in Malaysia? As we can see the graph, so ever since after the HIV pandemic began, the number of cases was rising all the while until a total of about almost 7,000 new case reported per year in 2002. So following that, as there's introduction of harm reduction strategy to IVDU patients and also free first-line ART in 2002, 2006. Then after that, followed by the implementation of ART regardless of CD4 count. Then we can see there is a reduction in number of cases to 2000, almost about 2012. So, but after that, for the past almost 10 to 15 years, the number of new cases reported each year has been plateaued without much significant changes, ranging around 3,300 cases. So, estimated key population were around 282,000 in the country. They were identified to be high risk but HIV negative according to this population survey done in 2018 and 2022. And HIV prevalence remains high among key population, in which estimated among MSM population about 12.9%, transgender 5.9% according to a behavioral study. So what are the advantages of TLD as compared to our current regime of the Tenver-M and efavirenz? First of all, it is more potent. It has high virological efficacy, so it can achieve viral load suppression more rapidly. Second, it is better tolerated. It has a good safety profile and high patient tolerance, in which generally the medications has So third, it is more durable. It has a higher barrier, means that it is more difficult to become resistant. And number four is it is more convenient. It is a once daily dosing regime that improves treatment adherence. So how to achieve this ending AIDS target 2030 by implementation of this TLD regime? So first is expanding the treatment coverage by increasing the number of PRHIV receiving ARV treatment from 68% in 2022 to target over 95% by 2030. So by doing this, it can accelerate the virus suppression in PRHIV who are already on treatment. So by accelerating and maintaining virus suppression, so patient can U equals to U target, which means undetectable equals to untransmittable. Thus, by preventing transmission, stop the spread of HIV to meet the goal of ending AIDS by 2030, targeting fewer than 900 new cases a year by 2030. Currently, 3,000, so there's still about 66% reduction to be aimed. And reduction of mortality, decreasing the number of deaths caused by HIV. So how to implement this is through strategy rollout and coverage. So universal MOH facility integration, and also make sure the medication to be sourced and available. The primary objective is to transition to over 95% of existing patient to T. So immediate protocol for new patients. So TLD should be prioritized as a first line ART for all newly diagnosed HIV/AIDS patient. So also through stage clinical transition for current patient who are existing patient using efavirenz into TLD. So this is according to the information attached in the circular released on April. So a little bit of introduction of what is TLD regime and how can we plan for the strategy rollout. So TLD regime is a fixed dose combination. So it is a single pill, so which is easier for patient to take, and it consists of tenofovir disoproxil fumarate 300 mg, lamivudine 300 mg, and dolutegravir 50 mg. So it is a standard dosage that it can be taken once daily, either in the morning or at the night time. So prerequisite that patient must make is there should be more than 40 kg, age above 12 years old, and also they do not have contraindication for the tenofovir, in which the creatinine clearance, if less than 50, then it is contraindicated because of the presence of tenofovir component, and also contraindicated in anyone who has known hypersensitivity to either tenofovir component or lamivudine component. So our target patient status, if the patient is treatment naive, then recommended to start the first line with TLD applicable to conditions.
Abang Apik mau ada yang kecil? Oh, tetap bayar sangar. Bahaya itu.
Sorry, unless presence of contraindication. So number two, then moving towards next step is to transition the stable first line patient who are currently on an NRTI, be it most of them or efavirenz or a small number on nevirapine, to be switched to TLD. Category 3 will be those 3, 4, 5 are under the hospital level care, which are those who have failed first line and RTI. They could be currently taking PI-based regime, so to switch to TLD, or those who are already stable on PI-based can be switched to TLD, provided there's no previous ratigraphin exposure, then no resistance testing is needed. So although there are some patients that were already on stable dolutegravir containing regime previously, who are taking the pill as a separate loose pill, can be switched to a combination pill. So generally, in most of the scenario, the patients should be switched to TLD unless there was specific contraindication. So this is to achieve viral load suppression, and also for patients with unsuppressed viral load prior to TLD check, we must address the adherence and psychosocial factor. So this is also to serve as a clinical decision guide. Our patients so generally can be divided into treatment naive patient, patients stable on treatment but switching from one classes to another classes to TLD, or the pathway 3, which patient either fail first line at the current moment, switch to TLD as a second line, or those who fail PI regime. Those who fail PI regime usually need to have a resistant test and also be referred to ID physician for subsequent determination of the regimen after interpreting the viral resistance test. So this in pathway 3, in failed patient, we do not automatically switch them. Usually we assess them first. So despite the combination of TLD could be suitable to most of the patient, there are certain special consideration that has to be taken before switching. So for example, one of the common drug-drug interaction will be those who are taking rifampicin-based TB treatment, because we know a number of our patients either when they are newly diagnosed, they may be diagnosed with TB infection at the same time, or even throughout their treatment course, they are still more prone to get TB infection. So for those who are on anti-TB, rifampicin has a significant drug-drug interaction with dolutegravir. It can significantly reduce the DTG plasma concentration, which usually will result in a requirement of dose adjustment. So usually the standard action will be we will need to give double dosing of dolutegravir. So if the TLD is a single pill consisting single dosing of dolutegravir, so if the patient needs double dosing of dolutegravir, either we may need to give the patient loose pill, or another strategy that we can which means that 1 tablet of 10 mg with dolutegravir 50 milligram BD, or another strategy is we can still give the patient 1 tablet of TLD fixed dose combination in the morning, but the dolutegravir loose pill in the evening. So there can be either option. So there are some studies showing that the standard daily dose of single daily dose dolutegravir is adequate, but this should be interpreted carefully, that only if the patient is taking the dolutegravir based regime as first line and has a CD4 count of more than 100, and sometimes we also need to consider that if the viral load is suppressed. So whether to consider the patient is suitable for single daily dosing dolutegravir while taking rifampicin, I think it sometimes has to be case by case basis, and in this if this situation appear, then please consult ID colleague first. So the next is, how about in patient who has previous integrase inhibitor exposure, such as ratigrapir? For example, there might be a category of patient that previously has allergy to efavirenz, and in the previous years when dolutegravir hasn't been available yet, they were being on ratigrapir. So whether those who are on ratigrapir can be automatically switched to dolutegravir, because ratigrapir has no longer been produced. It has been discontinued, but previous exposure remains a risk factor, whereby if the patient viral load wasn't suppressed, there might be increased risk of resistance to integrase inhibitor, in which we might need to check a viral resistance test first to see if any of the mutation resistance been present before being switching to the dolutegravir, because there's a potential need of double dosing of dolutegravir. So other than those significant consideration, how about general drug-drug interaction with other common medication? So the common medications that have interaction with dolutegravir includes anticonvulsants medications such as carbamazepine, phenytoin, phenobarbital, can significantly reduce the dolutegravir plasma concentration, in which it might potentially compromising the HIV virus suppression. So avoid co-administration with this group of anticonvulsant, and consider alternatives such as epilene, lamotrigine, levetiracetam, which is Keppra, and also topiramate. So if no alternative, may need to consider implement double dosing with 50 mg BD. Another common medication and common scenario, especially in our aging PL-HIV population, is that a number of them has metabolic comorbidities such as diabetes mellitus. So in which metformin is a common medication which we'll be taking together. So the dolutegravir can increase the metformin concentration, hence increase the risk of dose-related adverse effect. Therefore, it is recommended to initiate the metformin at lowest dose as possible, titrate carefully, ensure not to exceed total daily dose of metformin of more than 1 gram, with vigilant monitoring of signs of lactic acidosis, especially in patients who also have renal impairment such as diabetic kidney disease. So another group of medication that has potential interaction will be polyvalent cation, including supplements and also antacid. So if taken together, they can decrease the dolutegravir absorption because it bind and decrease the absorption. So we have to follow the rules of 2 hours before or 6 hours after. So I advise our patient to take the dolutegravir at least 2 hours before dose medication or 6 hours after dose medication, with special consideration while taking with empty stomach. So since TLD is known to be much more tolerated, but then does that mean that it doesn't have any side effect? So it is actually not. It does have a lower side effect profile, more tolerable compared to our current regime of efavirenz and 10-M, but it is not without any side effect. So even we are starting the patient or transitioning the patient to TLD, we must counsel them and remind them what are the expected side effects. One of the side effects is that it still has some CNS side effect. It is not that it is not present as compared to efavirenz, which the CNS side effects are quite common. This is less common, but still potentially to have, which includes insomnia, headache, vivid dreams, but often manageable by adjusting the medication timing. So for example, if patient has CNS side effects, we ask them to take the medication earlier. So as for lamivudine, it has a risk of hepatitis flare in those who are with hepatitis B co-infection. If they discontinue lamivudine based regime, the flare is possible. So generally, dolutegravir is having less risk of hepatotoxicity, but it is still present. Rashes is uncommon, but out of all the patients that we have
Kalau tak
prescribed,
semua benda kita kena order dari sini. So at least kita tahu.
sorry, so I will continue. Then occasionally we still see a little bit of hepatotoxicity, rashes, and hyperglycemia. So another common side effects is actually the weight gain, which can related to metabolic side effects as well that got to be monitored. So following that, for tenofovir, the side effects of TDF include sorry, excuse me, because there was a phone call. So I continue. So for the tenofovir, the common side effects that, as we know, includes mainly renal and also bone health. Tenofovir is potential to cause renal insufficiency, Fanconi syndrome, and serious tubular damage in about 0.5% of patients. In certain patients, the manifestation can start in a few months after initiating the TDF-based regime. There are also a number of patients which experience the renal impairment after many years of taking the medication. So, followed by the bone density impact, long-term use of the TDF-based regime is also known to be associated with increased risk of osteomalacia, and sometimes it leads to early osteoporosis and osteoporotic-related fracture. So, it also has common GI side effects in which in certain patients, they experience nausea, vomiting, flatulence, and diarrhea. As for the timing of medication, we can either recommend the patient to take the medication in the morning if the patient experiences insomnia, vivid dreams as side effects. If the patient is already used to take it at night or may potentially complain of dizziness and nausea during daytime, then they can continue to take it at night. So how about in terms of monitoring after started TLD, how do we monitor the patient and how frequent? As for creatinine, it has to be monitored 1 to 3 months post initiation because the litigurate-based regime can actually cause the creatinine level to rise by less than 25% or less than 30 millimole. It is still acceptable and it is slightly DTG related. For example, if the patient baseline creatinine is 60 to 70, after taking DTG-based regime, it increased to 90, but with a level of less than 30 millimole, it is an expected effect that is observed and it is still safe to continue. If the creatinine rise more than 25% or more than 30 millimole, then further workup need to be done to look for possible renal disease other than TLD cause, such as stone disease, diabetic kidney disease, prostate problem. If none of the other causes are present, all other causes has been excluded, then consider to change to other regime. For liver function tests, it is recommended to monitor 1 month post initiation because it has a small risk of hepatotoxicity. Lamivudine lamivudine itself does not cause Hep B flare, but discontinuation of lamivudine may cause a Hep B flare. So as for allergy and rashes, it is rare in all three components. Dolutegravir and lamivudine has a risk of less than 1%, whereas tenofovir TDF can have about 5 to 10%. And these are the preferred monitoring schedule. Viral load, usually after a switching regime, we will repeat the viral load in 6 months. If this is a new ARV initiation or change from a previous field regime, then we'll repeat after 4 months to assess the response. So thereafter, if the viral load suppression is achieved, we can back to the usual schedule. So for CD4, it is aligned with viral load. Initially about 4 months, then after that, if the patient is already stable, annually. So full blood count, renal function, liver function, usually we monitor the first one at 4 weeks after changing to the new regime, then subsequently can follow with the usual schedule according to the patient's condition, and to screen for metabolic side effects every 6 to 12 months. So with this, I would like to share a few clinical scenario of how could we consider to use TLD as first line or to switch the regime. So case number 1, Mr. R. He's a 66-year-old Indian man who is a smoker, alcohol drinker, take 4 to 5 cans of beer per day. So he's married, has 4 children, currently unemployed for the past 4 months, previously worked as a security guard, staying with the family. He had a recent motor vehicle accident in March 2026 and has become weaker since then. So mostly become homebound. So he has a background history of R.E.D. diagnosed since 2010 on ART and under regular follow-up with KK-Lakin. His other comorbidities are asthma and also dyslipidemia. His current regime is 10 mg 1 tab on night and efavirenz 600 mg on night. And his latest CD4 and viral load are good. CD4 834 with viral load not detected. So Recently, he's brought in by ambulance, informed by daughter that patient was found having suicidal attempt, lying on the bed, alleged Clorox injection. So this is this happened because he recently has a stressor, whereby the family found out that about his R.E.D illness recently during his admission for motor vehicle accident. So he was brought to the ED, suffering from after investigation. He has esophagitis, erythematous hemorrhagic gastritis, and chest X-ray also shows aspiration pneumonitis, in which these are the two X-ray taken 3 days apart. It was worsening. Patient required oxygen support, supportive treatment, steroid, and also high flow nasal cannula at its highest requirement. He also has a little bit of transaminitis, but resolving after all the medication has been withheld and with supportive therapy. So his condition has gradually improved, and now he's planned to be discharged. So which charity regime should we restart with? We have referred the patient to psychiatrists. They have assessed the patient a few times and think he has an adjustment disorder with depressive symptoms. So in this patient, we may consider to not to restart the efavirenz, even if his transaminitis has resolved, because he has this adjustment disorder with depression, and also already had a suicidal attempt. We could consider to change the first line treatment into TLD. So case 2 is Mr. S, who is a 49-year-old Malay gentleman. He has underlying diabetes, hypertension, dyslipidemia, and history of transient ischemic attack in 2020 under GP follow-up. This time around, he presented with cough for 2 weeks, shortness of breath as shown in the chest X-ray. The first one has bilateral lower zone ground glass opacity. So after a TB workout, he was also investigated for PCP. So he was started on treatment of PCP with bed trim, and also his lung condition getting better, as we can see on the second chest X-ray taken 1 week after treatment. The ground glass opacity started to reduce. And he's also newly diagnosed R.E.D with a baseline CD4 of only 21, viral load of 679,000. So after taking the Bactrim for about 1 week, he gradually developed mild transaminitis and a little bit of acute kidney injury. So the medication was changed to clindamycin and primaquine as a second line PCP treatment. So we also ran a urine lab for him to rule out TB because his CD4 is 21 and it was negative. So which ART regime is preferable? This patient, if follow the older regime, we could still consider to give him 10 mg and efavirenz if his transaminitis has resolved, and we can start this during the clinic follow-up. But what if there's still residual transaminitis, or provided now we have TLD readily available and first line, then this patient will be preferable started with TLD, because it could also has the benefit of rapid viral suppression since the patient has a very low CD4 and high viral load. So moving towards the third case, the third patient is Mr. F, who is a 26-year-old Malay gentleman, MSM. So he has already diagnosed since 2021 at the age of 21-year-old during a screening. So at that time, he had syphilis as well, RPR 1 to 128. His baseline CD4 was 240, viral is 268,000. So he was started on 10 mg and efavirenz. In between, he has seen in both KK, Sultan Ismail, and also ID Clinic HSA. So after taking the medication for 8 months, the repeat CD4 and viral load shows that CD4 is 284, viral load has become suppressed. However, patient has defaulted the treatment and follow up from 2021 to 2025 due to difficulty in accepting the illness. In October 2025, he has returned to care in KKSI again and restarted the same ART regime, which is 10 M1 TET on night in Faran 600 mg on night. This time around, his baseline viral load is 338,000. Patient is adherent to ART despite feeling stressful and uncertain about the medication. So a repeated blood test 4 months later after restarted ART shows that CD4 is 229, viral load has came down to 85. However, unfortunately, the patient is suffered from mental health issue in which he has complained of low mood for the past 4 years, unable to accept his illness. He has anhedonia. He also has frequent sleep, unable to function at work, feeling worthless and unsure what to do in the future. And also sometimes he has attempts of deliberate self-harm such as punching in the mirror and feeling anxious in crowded environment. Hence, he actually tried to take double dose of ART, which is loose pill of 10 mg and efavirenz, plus combination pill of Trasiba for 1 week prior to admission and got admitted. In further interview, the attempt to take double dose of ART is that he thinks that this could actually suppress the viral load at a more rapid rate. So he wanted to achieve viral load suppression faster by self-increase the medication to double dosing. So this has led to transaminitis in which his ALT is 188, AST 83, and hence ALT is withheld. So as the patient is still feeling anxious and depressed and is already diagnosed with depression by KK Kota Tinggi and also started on treatment. So which ART regime could we change to help with the patient so that he could possibly having better coping with the medication? So lastly is case number 4. Mr. M, he's a 29-year-old man with newly diagnosed R.E.D. He was presented to HSI in 2024 with symptoms of acute seroconversion illness. His baseline investigation shows that Hep B, Hep C, and RPR were non-reactive. His TB workup was also negative. His CD4 was 480, which is still at a fairly good level, more than 350, and his viral load is 49,200. So he was started on 10 mg and efavirenz. So 6 days later, he presented to KK with rashes for 6 days, gradually involving the whole body with ALT of 55 and eosinophil of 0.37. So this picture is to show how extensive the rashes are. It involves the trunk, back, upper and lower limb as well, which is a grade 3 rashes, more than 30% of the body's surface area. So he was diagnosed with maculopapular eruption secondary to efavirenz. There was no DRESS syndrome and ART was withheld. So in this situation, TLD is the choice as well to because the patient already has rashes with efavirenz, we are not going to re-challenge that. So with all those cases, I would like to summarize that TLD is now a preferred first line, provided the medication is available. And I know in some of the PKD, the medication is already available. So it should be given to the patient because of high potency with rapid suppression. It has a superior tolerability, higher resistance barrier, reduced fear burden for the patient, and also fewer drug-drug interactions with fewer side effects. So with that, I end my presentation. I would like to take the opportunity to share about this, that this year, Martian is going to have a National AIDS Conference from 18 to 19 of September, with 17th of September being the pre-conference workshop. I think the venue is going to be announced soon. So hopefully for those who are interested, could take the opportunity to join the conference. So with that, hopefully, with our effort together, we could achieve our target of ending AIDS by 2030. So thank you everyone for the attention.
Okay, thank you, Dr. Tuang. Is there any question to Dr. Tuang? There is one question here. Doctor, if patient could not tolerate efavirenz but viral load is suppressed, do we need to do the test first before change to TLD?
Sorry, if the patient is on efavirenz.
Yes.
Yes, and
but viral load is
sorry?
suppressed, do we need to test first before change to TLD?
Do we need to test the resistance? Is it? The question is.
Yes, I think the resistance test.
I think that's the question. So, first of all, the viral resistance test, which is available now, is only suitable to be sent when the viral load is not suppressed. So, meaning to say that before we could order the viral resistance test, the patient has to have a viral load of more than 1,000. So if the viral load is suppressed, like not detectable or less than 40 or even less than 1,000, the lab method will not be able to sequence the resistance. So it will not be able to detect any mutation. This is because of the method available in our country could only detect the limit when it is more than 1,000. So therefore, if the viral load is suppressed, there's no need to send any resistant tests because first of all, it cannot be tested as well. Second is the patient falls into the suppressed category. So we can just change, but we can repeat the viral load again in 6 months' time.
Okay, thank you, Dr. Tong. Is there any question from the floor? Boleh scan QR untuk kehadiran
Actually, Dr. Radiato,
Hello. Can I just ask whether this regime is it good for pregnancy, a woman or planning for pregnancy patients?
Yes. The regime is what we give for the pregnant lady, in fact, especially for those who are at the moment, because we still do not have the medication for everyone. So we will prioritize to give to those pregnant lady who are diagnosed in second trimester or approaching third trimester, especially in order to get the benefit of rapid viral suppression. It is not contraindicated in pregnancy. In the earlier years when it was first started to be rolled out, WHO does have a clause to say that there might be potentially associated with neural tube defects. But after that, there were newer data, a newer study that has already superseded the problem. So it is proved to be safe in women with childbearing age.
Okay, there's another question. Hi, Dr. Tuang. I would like to ask, in view that we are starting as first line, what happens if patient develop virological failure with TLD? How do we manage these cases?
Yes, thank you. I think this is a very good question. So because the TLD has resistance, it is not that it wouldn't develop resistance despite it is said to have higher barrier. So if patient has developed resistance or let's say the viral load is unsuppressed after taking TLD, other than checking the adherence, another is we can send a viral resistant test. So in the resistant test form, we have to specify that we want to check integrase inhibitor resistance. If the resistance is confirmed, which means the specific viral mutation is detected, then we should move to protease inhibitor, which means that it is still back to our Kaletra atazanavir, but Kaletra atazanavir are not the preferred not the preferred choice because the preferred protease inhibitor with high barrier to viral resistance would be darunavir, ritonavir. And as for my understanding now, we are trying to get the darunavir, ritonavir into our formula as well. So in order to prepare to face this dolutegravir resistance after it has been widely used as first line. The medication darunavir, ritonavir is available in Malaysia, but at the moment at a small amount. If we have a case, we will contact Hospital Sungai Buloh to get the stock. We have arranged for some of the patient before this for temporary use, but if we indeed patient required this, currently we are in the process of getting the combination pill.
Okay, another question. A patient with a history of treatment default but defaulted heart, Tenviram and efavirenz for 3 months, noted a viral load raised more than 1,000. Will you recommend to test virological test first before switch to TLD?
I think this is a very good question as well. So the viral resistant test has to be the prerequisite to order a viral resistant test is that the patient has to be on the filling regime. Because if the patient has not taken, in the scenario that the patient has defaulted the medication, for example, 3 months, 6 months, and then now the viral load has become high, if we are sending viral resistance at this point when the patient is ART free, we won't be able to detect any resistance because the resistance gene is usually induced after the patient is on treatment. When the viral resistance is sent while the patient is not on treatment, most likely it will detect the wild type virus but not the resistance virus. So it may give us a false negative result in which we may think that the patient does not have any resistance. So usually what we could do is after we restart, at the current scenario is that our current practice is that we restart the patient back on the first line before the default. If after 4 months, let's say the viral load is still not suppressed, for example, maybe it was 20,000, 4 months later, it came down a bit, but it is still 10,000, then this is the point that to send viral resistant test.
Okay. And for a patient, for a patient who is already on metformin, 1 gram BD, if switch heart regime to TLD, should we reduce the metformin dose to 500 mg BD?
I think the recommendation is actually yes, but then we also understand that there are situations that patient is actually taking metformin 1 gram BD with the dolutegravir, but they could tolerate well. But I think if we would like to do this, we have to be very cautious about the side effects because the dolutegravir increase metformin concentration. So we have to check whether the patient has experienced any side effects before we would like to do that. So ideally, we should reduce to 500 BD and use other anti-diabetic medication.
All right. Okay, another question. Hi, Dr. Tuang, can you quickly explain again which patient on rifampicin that can use only single dose of DTG? Can this apply for 3-HRTPT?
Can we apply to what, sorry?
Can this apply to 3-HRTPT for TB? Rifampicin.
For the latent TB treatment, the one that 3HR.
Yes.
Okay. So usually I think this could be case by case basis. So at the moment in our practice, we still do not actively encourage to use single dosing dolutegravir, but theoretically is that there was some study which says that single dosing can be considered in patients who are viral load well suppressed and also the CD4 is more than 100, and this is not a second line treatment but a first line treatment. So I think if we would like to consider that, then it may have to be consultation or discussion with the ID physician before we do this, unless updated national guideline has a clear recommendation on that. I think that this practice is a bit variable among in the ID fraternity as well. So as for Johor team, we are still preferred to give double dose of the litigator in order not to take a risk. But there might be update from time to time that we have to follow. Yeah.
Okay, for R.E.D patient with concurrent hepatitis B infection, is it recommended to change to TLD regime as there is a risk of hepatitis flare if it is stopped?
Actually, TLD regime is not contraindicated. It can be given for patient with Hep B because it also contains the tenofovir. So I think the tenofovir, my understanding is that both tenofovir and lamivudine has anti-Hep B property, but tenofovir is the main component. So I think the statement is that if let's say the patient is on TLD and patient has HIV and Hep B core infection, but as the patient gets aging and EGFR and creatinine clearance reduced to less than 50 later on, and you may want to consider to stop the tenofovir lamivudine component and let's say change to something else like Kyrexia plus the litigator, then at that time have to be aware of the risk of Hep B flare and the patient has to be referred to gastro to get the anticardial.
Is there any question? So I think that will be our last question. So thank you, Dr. Tuang, for the excellent and insightful presentation. On behalf of Uni HIV, STI and Hep C, I would like to extend our sincere appreciation to Dr. Tuang for sharing her expertise and valuable perspective. Thank you as well to all participants. I hope everyone already scanned the QR for registration. So with that, we conclude our CME webinar today. Thank you and Selamat Hari Raya.
Okay, thank you. Thank you, Dr. Radhaton. Thank you, everyone. I think, Dr. Radhaton, if there are still questions from the FMS and also our KK colleague, maybe we can collect the question and direct it in the written format. I can still try to reply or answer as much as I could. Okay?
Okay, Dr.
Okay, thank you very much.
Thank you.
Bye.